If there's one topic in orthopedics that shows up on every single exam without fail, it's this one. We're talking about osteoporosis today, and by the end of this video you'll understand exactly why examiners love it so much. It lets them test pharmacology, endocrinology, and radiology all in a single question. Alongside it, we're covering two more high-yield conditions, Paget's disease of the bone and osteogenesis imperfecta, and then we'll bring it all together with a comparison table that will let you crack almost any metabolic bone disease question thrown at you. This is part 2 of our Metabolic Bone Diseases series, built for MBBS students and PG aspirants who want the concepts explained properly, not just memorized. Let's get into it. Let's start with osteoporosis, because it really is the single most important topic in metabolic bone diseases. It's asked in nearly every exam cycle, so it's worth getting completely comfortable with. So what is it exactly? Osteoporosis is a quantitative bone defect, not a qualitative one. The bone that is present is completely normal in composition, normal osteoid, normal mineral. There's just less of it. Compare this to the other metabolic bone diseases we've discussed. In rickets or osteomalacia, the osteoid is present but poorly mineralized, which is a qualitative mineral defect, and in osteogenesis imperfecta, which we'll cover later in this video, the osteoid itself is abnormal while the mineral is normal, a qualitative collagen defect. Osteoporosis is different from both of these. It's a pure reduction in the quantity of otherwise normal bone. Now, your bone is a dynamic tissue. Throughout life, there is constant bone formation by osteoblasts and bone resorption by osteoclasts, held in balance. Early in life, the balance favors formation, so bone density increases. It peaks. This is your peak bone mass, achieved around the age of 30 years, and after that, the balance progressively shifts toward resorption, so density declines for the rest of life. This shift happens in everyone, but there's a sharp acceleration in women somewhere between the ages of 50 and 70, roughly 60 to 65, caused by menopause. Estrogen is protective for bone density, and its sudden decline at menopause causes a rapid drop in bone density in women that doesn't happen the same way in men. Here's a high-yield distinction that gets tested directly. The most common cause of osteoporosis is age. This is called senile osteoporosis because it eventually affects everyone. But the most common risk factor for osteoporosis is menopause. This exact distinction, cause versus risk factor, has been directly tested, so make sure you can tell the two apart. One more thing before we move on. What determines your peak bone mass? Genetics, nutrition, and physical activity through the growing years. And what determines the rate of decline after that peak? Again, genetics, race, and activity and nutritional status. Now that we know what osteoporosis is, let's look at who's at risk. The risk factors split into two groups. The non-modifiable ones are age, race, and female sex. And interestingly, Asian populations are more predisposed to osteoporosis compared to other races. The modifiable ones are physical activity and exercise, nutrition, alcohol use, and smoking. Bone-loading exercise and good nutrition preserve density, while alcohol and smoking are both detrimental. Osteoporosis itself is broadly divided into two categories. Primary osteoporosis is due to factors outside your control, such as age and menopause, and this is the more common category. Secondary osteoporosis is due to identifiable, often modifiable causes. The most common of these is drug-induced, and specifically steroids. In fact, steroids are behind the majority of drug-induced problems seen in orthopedics generally, so it's worth remembering this association broadly, not just for osteoporosis. Beyond steroids, secondary osteoporosis can also come from hormonal excess states like Cushing's syndrome, from immobilization, from weightlessness as seen in astronauts, and from rheumatoid arthritis. Immobilization deserves a closer look because it's a very important cause. Bone is a dynamic tissue that only strengthens under load, So a battered in patients and used bones progressively lose density. The same logic applies to weightlessness in astronauts. The bones simply aren't being loaded. Here's an MCQ pearl worth remembering. Immobilization and weightlessness-related bone loss tends to be localized to the unused bones rather than generalized throughout the skeleton. This actually leads into a worked question that's been asked in a past exam. In a bedridden or hemiplegic patient, which part of the skeleton loses the most bone density? Let's reason through it. Lower limb bones start out denser than upper limb bones because they bear weight every day. When a patient becomes immobile, density falls in all the unused bones. But since upper limb bones started less dense to begin with, they show a greater relative loss. And within the upper limb, proximal bones lose more density than distal ones. Putting that together, the answer is the proximal humerus. The rule to remember: upper limb loses more than lower limb, and proximal loses more than distal. And in a hemiplegic patient specifically, this loss occurs on the paretic or affected side. So what does this actually look like in a patient? The classic patient is an elderly, postmenopausal female. Her earliest and most common complaint is pain, particularly in the lower back, and importantly, this happens before any visible fracture occurs. Weakened bone develops microscopic, trabecular fractures well before a frank fracture, and these microfractures are what generate the early pain. This is actually a general principle worth remembering beyond osteoporosis. It's a hallmark of pathological fracture in weakened bone. Now, lab investigations are classically normal in osteoporosis, and this is tested relentlessly. If any lab value is described as abnormal in a question, it is very unlikely to be osteoporosis, at least for exam purposes. As the disease progresses, those microfractures give way to actual fragility fractures, fractures from trivial trauma, because the bone can no longer bear normal loads. There's a specific order of frequency worth memorizing. Vertebral fractures are the most common because the vertebra shows the earliest manifestations. Hip fractures come next, either neck of femur or intertrochanteric fracture. And Cole's fracture, the distal radius fracture, comes third. Repeated vertebral compression produces the classic kyphotic deformity and progressive loss of height you see in elderly patients. And it's worth remembering, they aren't bending forward out of respect. They're bending forward because their vertebrae are compressing anteriorly. Let's go through the radiological findings. On a lateral spine film, you'll see vertebral wedge compression. The anterior vertebral body height is reduced relative to the posterior height, when normally these two are equal. You'll also see Cole's fracture, which is an extra-articular fracture of the distal radius and neck of femur fracture. And then there's a really distinctive finding called codfish or fish mouth vertebrae. The vertebral end plates bend inward around the intervertebral disc, giving an appearance that radiologists liken to the shape of a codfish's mouth. Important nuance here. This finding is not pathognomonic for osteoporosis alone. Osteomalacia and even osteogenesis imperfecta can also produce codfish vertebrae. But osteoporosis remains the most common cause. One critical limitation to keep in mind: radiographic changes of osteoporosis only become visible once roughly 30% of bone mass has already been lost. So by the time you can actually see it on a plain X-ray, it's already a late finding. And that's exactly why screening matters, which brings us to our next section. Let's talk about how we actually screen for and diagnose osteoporosis, starting with the imaging options. Quantitative CT scan is not preferred. It's expensive and delivers unnecessary radiation exposure for a diagnosis that doesn't need it. Single photon emission absorptiometry, or SPA, is reasonably good, but its major limitation is that it only measures density at one localized site rather than giving a generalized picture. And then there's the DEXA scan, dual energy X-ray absorptiometry, which is the investigation of choice. It has low radiation, clear diagnostic value, and it's inexpensive and accessible. Here's an interesting fact. DEXA technology was originally developed to measure body fat content and was only later repurposed for measuring bone density. The sites assessed are the spine and the hip, since these are the regions most commonly affected. Now, DEXA gives you two scores, a T-score and a Z-score, and the difference between them is frequently tested. The T-score compares the patient's bone density to a healthy young adult of the same sex and race, but at peak bone mass age, around 30 years. The Z-score compares the patient's bone density to a healthy person of the same sex, race, and same age. Why is the T-score preferred over the Z-score? Think about it this way. If you compared an elderly osteoporotic patient's density only against another elderly person of the same age, using Z-score logic, both may show similarly low density and appear relatively normal to each other, even though both are genuinely osteoporotic. It's like comparing two people with poor vision to each other. That doesn't tell you either of them sees normally. You need to compare against someone with normal vision. That's why the T-score, compared against the young healthy peak bone mass standard, is the preferred metric. Now let's get to the WHO T-score classification, which you absolutely have to memorize. A T-score of 0 to -1 standard deviation is normal. -1 to -2.5 standard deviations is osteopenia. -2.5 standard deviations and below is osteoporosis. And -2.5 standard deviations and below, combined with a fragility fracture, whether that's vertebral, Coles, or hip, is severe osteoporosis. Let's work through an example. A T-score of -1.25 gives you osteopenia. A T-score of -2.5 gives you osteoporosis. A T-score of -2.6 also gives you osteoporosis. And any of these, if there's an accompanying fragility fracture, becomes severe osteoporosis. So who should actually get screened? According to National Osteoporosis Foundation recommendations, females age 65 or older should be screened with DEXA, and males age 70 or older should be screened with DEXA. Age 65 is actually a critically important number in orthopedics generally. Treatment decisions, screening, and management approaches shift around this age threshold in multiple orthopedic contexts, not just osteoporosis. This exact screening age fact has been repeated as a question multiple times across exams, so hold on to it. Let's re-emphasize the lab findings in osteoporosis one more time, because it's so heavily tested. Calcium is normal. PTH is normal. Phosphate is normal. And ALP is normal. If any of these are abnormal in a question stem, it is not osteoporosis, at least for exam purposes. Now let's move into management, starting with the medical side. Treatment for osteoporosis has two broad pillars: medical management, which is aimed at correcting the imbalance between bone resorption and formation, and surgical management, which we'll cover shortly, for established fractures and deformities. The drugs used fall into three functional categories. First, drugs that decrease bone resorption, also called anti-resorptives. This group includes bisphosphonates, which are the drug of choice and which we'll get into in more detail in a moment. It also includes denosumab, a monoclonal antibody against rank ligand. By inhibiting rank ligand, osteoclast activation is blocked, which inhibits resorption. Then there are selective estrogen receptor modulators, or SERMs, like raloxifene and tamoxifen. And finally, hormone replacement therapy, or estrogen, used in postmenopausal women. Second, drugs that increase bone formation, the anabolics. This group includes teriparatide, a synthetic parathyroid hormone analog, abaloparatide, and romosozumab, an anti-sclerostin monoclonal antibody. And third, there's a drug that does both, strontium ranelate. It's theoretically ideal, since it decreases resorption and increases formation at the same time, but it is not used in current practice due to hepatotoxicity risk. So when it comes to the drug of choice, whatever the clinical scenario, postmenopausal, elderly, steroid-induced, the reflex answer for osteoporosis treatment is bisphosphonates. Mechanistically, they inhibit osteoclasts, decreasing bone resorption. There are three bisphosphonate names worth remembering, and the easiest way to keep them straight is by their dosing frequency. Risedronate, or risedronic acid, is given once a week. Ibandronate, or ibandronic acid, is given once a month. And zolindronate, or zolindronic acid, is given once a year. Zolindronate's once-yearly dosing gives excellent compliance, which is a big practical advantage. Alongside bisphosphonates, patients should receive calcium and vitamin D supplementation. And if pain is prominent, calcitonin is useful because of its specific analgesic action on bone. Now, here's something important to understand about long-term bisphosphonate use. Bisphosphonates work by suppressing osteoclast activity, but prolonged suppression, typically after around 5 years of continuous use, though some sources say 3 to 5 years and others say 5 to 7, can excessively inhibit osteoclasts. And since healthy bone strength depends on both osteoblasts and osteoclasts working together, excessive osteoclast suppression paradoxically weakens the bone. This produces what's called an atypical fracture, a complication of long-term bisphosphonate use. These occur specifically at the subtrochanteric region, on the lateral cortex of the femur, below the trochanter. Here's an important distinguishing point. This location is different from the looser zones, also called milkman zones, seen in osteomalacia, which occur on the medial side of the femoral neck. Atypical bisphosphonate fractures occur on the lateral subtrochanteric cortex. Don't confuse the two. A simple way to remember the numbers here is the phrase 555. Bisphosphonates can be safely used for roughly 5 years, and even beyond that. Only around 5% of patients go on to develop these atypical fractures. Because of this risk, patients who have been on bisphosphonates for 3 to 5 years are given what's called a drug holiday. Bisphosphonates are stopped for a period, roughly 6 months to 1 year, during which alternative drugs are used, denosumab, estrogen or HRT, or one of the anabolic agents, before restarting bisphosphonates. Now let's understand how the anabolic drugs actually work, since this is a frequently asked, "How does it work?" type question. Take teriparatide. It's a synthetic parathyroid hormone. And this raises an obvious question. PTH normally causes bone resorption by acting through osteoblasts to release rank ligand. So how can a PTH analog build bone instead? The answer lies in dosing. Osteoblasts require a sustained, higher level of PTH stimulation to release rank ligand. When teriparatide is given in small, intermittent doses, it activates osteoblasts directly without triggering rank ligand release. So you get pure anabolic, bone-forming activity without the resorptive side of PTH signaling. Abaloparatide works on the same principle. Romosozumab, on the other hand, works differently. It's an anti-sclerostin antibody. Sclerostin is a natural osteoblast inhibitor, so by blocking sclerostin, essentially inhibiting the inhibitor, osteoblast activity, and therefore bone formation, increases. There's also an emerging treatment approach worth knowing. In patients presenting with severe osteoporosis complicated by fracture, there's a growing preference to start with an anabolic agent, teriparatide, first, to rapidly increase bone density, and then transition to bisphosphonate maintenance therapy once density has improved. This reflects the underlying pharmacology. Anti-resorptives only slow further decline and allow a slow, gradual increase, while anabolics can rapidly increase density. Let's move to the surgical side of management, starting with deformities. For kyphotic vertebral deformity from compression fractures, the approach depends on stability. A stable compression is managed conservatively with a talar brace, which is a spinal support brace. An unstable compression needs a procedure, and there are 2 options. Vertebroplasty involves passing a needle into the fractured, compressed vertebra and injecting bone cement, polymethyl methacrylate, the same material used in intraocular lenses, to hold the fracture fragments together. This does not restore vertebral height. Balloon kyphoplasty, on the other hand, uses a balloon-tipped needle inserted into the collapsed vertebra and inflated, which does restore the lost vertebral height. The resulting cavity is then filled with bone cement. Because it restores height, balloon kyphoplasty is generally preferred over simple vertebroplasty when there's collapse to correct. Now let's talk about fixing fractures in osteoporotic bone more generally. Osteoporotic bone is weak, so standard screws are prone to cutting out. The solution is a locking plate, a plate whose screw holes are threaded, so that inserted screws lock directly to the plate itself. This means the load transmits through the plate screw construct rather than relying on screw purchase in weak bone, which greatly reduces the chance of screw cutout. Let's shift gears now and talk about Paget's disease of the bone, also known as osteitis deformans. This is a condition of abnormally increased osteoclastic activity, and it unfolds in 3 phases. First, the lytic phase, where excessive osteoclast resorption breaks down bone. Second, the mixed phase, where resorption and new bone formation occur together. And third, the blastic phase, once resorption has run its course, or osteoclast activity exhausts itself, and formation becomes the dominant process. The pathology really comes down to increased bone turnover. And whenever bone turnover is high, expect elevated alkaline phosphatase, or ALP. In Paget's disease, essentially everything else in the lab stays normal. As for etiology, in most cases it's idiopathic. The exact cause is unknown. But there are 2 associations worth remembering: a mutation in the SQSDM1, or sequestosome 1, gene, and an association with prior paramyxovirus infection. For epidemiology and localization, there's a handy mnemonic, P for Paget's. It occurs typically in elderly patients, males more than females. The most commonly affected bone overall is the pelvis, a flat bone. The most commonly affected long bone is the tibia. And the most common clinical feature is pain. So remember it as P for Paget's, P for pelvis, P for pain. Now, why is the bone quality so poor in Paget's disease? Because formation has to constantly try to keep pace with high resorption, the resulting bone is structurally poor. It's more vascular, more fibrous, more woven, and mechanically weaker than normal lamellar bone. This immature bone is prone to bending, deformity, and thickening. And because of the excess vascularity, affected bones are classically warm to touch. Since Paget's disease often affects multiple bones simultaneously, this increased vascularity can actually become systemically significant, which we'll come back to when we talk about complications. This weakened, bent bone develops a characteristic fracture pattern that's been nicknamed the banana fracture because it resembles a fractured banana. It's a purely descriptive term, not a mechanistic one. There's also cranial involvement to be aware of. Abnormal bone formation in the skull causes stenosis of the cranial foramina, compressing the nerves that pass through them. The commonly affected cranial nerves are 2, V, 7, and 8, with C and 8 involvement causing hearing loss. And here's an MCQ pearl. Hearing loss in Paget's disease can occur through 2 separate mechanisms: direct compression of the vestibulocochlear nerve, CN8, from foraminal stenosis, or through associated otosclerosis, which some patients with Paget's disease also develop. Both mechanisms have been tested, so know them both. There's also a classic clinical clue worth remembering. Patients don't present complaining that their skull is thickening. Instead, they typically say something like, "My hat size keeps increasing," or "I bought a new cap, and within weeks it's tight again." This reflects progressive skull, or calvarial, thickening. Let's go through the radiological findings, organized by phase. In the lytic phase, you'll see a flame-shaped, or blade of grass, appearance in long bones, a resorption pattern shaped like a flame or blade of grass, and in the skull, a circumscribed lucent lesion called osteoporosis circumscripta. In the mixed phase, you'll see a picture frame vertebra, where the vertebral end plates and anterior and posterior walls appear denser relative to the lucent central body, giving a picture frame outline. You may also see an ivory vertebra, which is uniformly dense and bright, and a cotton wool skull, with patchy areas of bone formation and resorption side by side. And in the blastic phase, you'll see a tam o'shanna skull, anterior bulging or swelling of the skull's diploic space, resembling the shape of the tam o'shanna hat, a traditional Scottish cap, named after the title character of a poem who's depicted wearing it. If diagnostic certainty is needed, a bone biopsy shows a mosaic pattern, a mixed picture of resorption and formation occurring side by side within the same sample. Now let's talk about complications. The most common cause of death in Paget's disease is high-output cardiac failure. The mechanism here is that widespread increased bone vascularity across multiple affected bones demands a higher cardiac output than the heart is designed to sustain, and this eventually precipitates failure. Beyond that, there are the banana fractures and cranial nerve compression we've already discussed. And there's also secondary or pagetoid osteosarcoma, a recognized risk in elderly patients with a history of Paget's disease and a distinct subtype of secondary osteosarcoma. As for treatment, since the core problem is excessive osteoclast activity, treatment is aimed at suppressing it. The drug of choice is bisphosphonates, specifically the long-acting agent zoledronate, or zoledronic acid. And calcitonin is useful for managing bone pain, given its strong analgesic action in bone. Let's move on to our third and final condition for this video, osteogenesis imperfecta, also known as brittle bone disease. The underlying defect here is genetically abnormal procollagen. The osteoid itself is structurally abnormal, a qualitative defect, while mineralization is normal. The associated gene defect is in COL1A1. There are two inheritance patterns to know. Autosomal dominant is the milder form, and patients survive. Autosomal recessive is the severe form, type 2, and it's lethal. Affected pregnancies typically result in stillbirth. The clinical hallmark of osteogenesis imperfecta is multiple fractures at different stages of healing. Because the collagen is structurally weak, fractures occur with trivial force, one today, another 2 weeks later, another 3 weeks after that. And since they occurred at different times, they'll each be found healing at a different chronological stage when imaged together. This raises a critical differential you need to think about: battered baby syndrome. Multiple fractures in a child should always raise suspicion of non-accidental injury, and this must be actively ruled out. So how do you tell them apart? In osteogenesis imperfecta, the fracture location is diaphyseal, whereas in battered baby syndrome, it's metaphyseal. The history from caregivers is consistent with a fragile bone disease in OI, but inconsistent and implausible in battered baby syndrome. And in OI, you'll find associated features like blue sclera, which are absent in battered baby syndrome. So a simple way to differentiate the two: check for blue sclera and other stigmata of OI. If present, the fractures are more likely explained by the underlying bone fragility rather than abuse. Some other clinical features of osteogenesis imperfecta to know: labs are normal, there's blue sclera, delayed dentition, and easy bruising. In terms of management, protective bracing and cushioning form the mainstay, and honestly, this is a genuinely difficult situation for parents, who often have to swaddle affected children heavily and avoid even firm hugs for fear of causing a fracture. As deformity progresses with growth, correction requires a realignment osteotomy. The bent bone is cut into multiple segments and rethreaded over an internal rod, resembling a shish kebab arrangement of bone fragments, which is why it's informally nicknamed the shish kebab operation. The formal name for this procedure is the Sofield-Miller operation, using a Dubow rod. Now let's bring everything together with the single most useful table for your exam. Once you can reconstruct this from memory, you're set for this entire topic. We're comparing calcium, PTH, phosphate, and ALP across all the metabolic bone diseases. In rickets, osteomalacia, and secondary hyperparathyroidism. Calcium is low, though it eventually normalizes, PTH is high, phosphate is low, and ALP is high. In renal osteodystrophy, calcium is low, PTH is high, and ALP is high, same as before, but phosphate is high, and this is the key difference. In osteoporosis, everything is normal. Calcium, PTH, phosphate, and ALP are all normal. In primary hyperparathyroidism, also called osteitis fibrosis cystica, calcium is high, PTH is high, phosphate is low, and ALP is high. In Paget's disease, calcium, PTH, and phosphate are all normal, but ALP is very high, often 3 to 20 times normal. In osteogenesis imperfecta, everything is normal: calcium, PTH, phosphate, and ALP. And in scurvy, everything is also normal because it's a collagen defect, not a mineralization defect. Now, rather than just memorizing renal osteodystrophy, let's reason through it, because that'll help it stick. Kidney failure impairs calcium retention, which leads to low calcium. That triggers a compensatory rise in PTH. But the kidneys can't respond by excreting phosphate, so phosphate stays high. And this is unlike primary, vitamin D-driven osteomalacia, where phosphate is low. This is the key distinguishing feature between renal osteodystrophy and simple rickets or osteomalacia. Let's bring it all together. Osteoporosis is a pure quantity defect of otherwise normal bone, driven above all by menopause and aging, diagnosed with a T-score on DEXA, and treated first line with bisphosphonates, with anabolics like teriparatide reserved for severe, fracture-complicated disease. Paget's disease is a disorder of excessive, disorganized bone turnover, recognized by a sky-high YLP with otherwise normal labs, and remembered through its 3 phases and their radiological signatures. And osteogenesis imperfecta is a collagen problem, not a mineral one, distinguished from abuse by fracture location and the presence of blue sclera. This table you just built is genuinely one of the highest yield tools in orthopedics. Go back and redraw it from memory a few times until it's automatic. If this helped clarify things, hit like, subscribe for the rest of the Metabolic Bone Disease series, and drop your questions in the comments. I read every one of them.